welcome back to another episode of my Little Pinay Nurse podcast. For today's episode, I'm going to be talking about the 10 common nursing mistakes that we can easily avoid. This is just my personal opinion and it's based on my observations in the ward as a nurse for 5 years now here in the UK. And hopefully it will give you insights as well or help a lot of new nurses to be aware of these common mistakes and to avoid it from happening. But just to let you know, mistakes are normal. We're just human, right? But if you make mistakes, you have to make sure you do something about it. You report it. You tell everyone, the doctors, pharmacists, everyone else. And it's called the duty of candor. And I actually made a video about it before, duty of candor. And that was the biggest mistake I've made. After that, I was very careful of giving medications as well. And if you're interested, you can watch that. I'll include the link on the description below. And then you make a reflection about it as well. What are you gonna do next time? And things like that. So, yeah. But anyway, the first one is when giving a controlled drug like morphine or oxycodone, sometimes we give the modified release instead of the immediate release or vice versa because they're the same name. There's morphine immediate release and morphine modified release. So, modified is the long-acting one and that's good for 12 hours. The immediate release is usually given every 2 to 4 hours and that one is a fast-acting one where when you give, it will take effect in a few minutes time. A lot of nurses would have this common mistake of giving, for example, an immediate release instead of the modified release tablet. And if that happens, you just need to do duty of candor, let the doctors know, let the pharmacists know as well so that they can advise on what to do. If there's a lot of errors about it or bigger issues, the police could be involved because it's a controlled drug, basically. So yeah, you have to be careful, double, triple check, especially if it's a controlled drug. Don't rely on your colleague. It's a two signature. You have to double check with someone else, a nurse who has a pin as well. And sometimes what tends to happen is that one nurse just relies on the other. They don't check anymore. But don't do that. Even though that other nurse is working there for a long time already and you trust that person or they're already senior nurses, you still have to check it for yourself because that's the purpose of having a double check, to make sure that we reduce the mistakes of giving the wrong controlled drugs. And then number 2 on my list is not informing doctors about patients' health issues. So for example, the patient is having fever, but they're still awake, they're talking, they're still looking okay. But because you're not concerned, you forgot or you didn't tell the doctor about it. And in the end, when they see the observations chart and they see that the patient has fever and they didn't know, then you're going to be questioned about someone didn't tell me about this. So just tell them everything about your patient and then they will decide if they want to do something about it or not. Patient's review is always important. So you have to communicate whatever has changed on the patient's health, their observations, even though they look like they are still okay. Number 3 is not documenting properly, especially when doing blood transfusions. I mentioned that because it happened to me personally when I gave a blood transfusion and then it was still running and then my shift has already ended. So I didn't put anything on the time ended. I just put the time started and then I handed over to the nurse for the night shift. When it ended, maybe she forgot to write down the time ended, and eventually the people from blood transfusions, they check on all of these papers. My manager asked me what happened, why there was no time ended, and then I just have to explain that it was the end of my shift. In every trust, there's always a blood transfusion people who would always check on these papers that we sign off when we give the blood transfusion. Why am I tongue twistering on this? But anyway, because these people has a lot of time to make datex and incident reports. They're just doing their job anyway. But I mean, incident reports are not too bad, but a lot of people are scared about it. But it's more on a learning opportunity for everyone. And it's also a way of making things better. And then the 4th one is not detecting sepsis early on. During my time working in the ward, I've seen a few patients who they look like they're having sepsis. So now, if I see a patient, I would know that they're having sepsis or some other kind of deterioration. So these are patients who sometimes they just close close their eyes most of the time and they're just breathing so fast and their numbers are still good, blood pressure, heart rate are still good. The only thing that is different is their breathing is a bit higher. Sepsis is very serious and it's life-threatening as well. So make sure that when you have that kind of patient, you do something about it. You inform your senior staff, the nurse in charge, or the doctors and let them know if you need a review for this patient. It's good to read about the sepsis 6 as well. It's just a guidance for nurses and doctors on what's the initial thing to do if they're suspecting sepsis for a patient. So the 3 ins are like oxygen, IV fluids, and antibiotics. And the 3 outs are like monitor the urine output, check the lactate, and check for bloods, I think. If I'm not mistaken. You don't have to wait for the sepsis to progress. You can do whatever you need to do early on. And you don't have to wait for a patient to have a fever because fever is like a late indication of the sepsis. Try to practice 1 minute of checking the respiratory rate. Some people would do like 30 seconds and then they just multiply it by 2 or 15 seconds. 15 seconds and they just multiply it by 4. But it's still a good practice to do a full minute count of the respiratory rate. And then number 5 is neglecting critical meds. It's like regular medications for patients that cannot be delayed or cannot be omitted unless there's nothing that we can do anymore. These are like meds that we need to put some urgency on. For example, anti-epileptic drugs, you have to make sure that it's available. If you see that a patient has been admitted and they forgot to bring their anti-epileptic drugs, you have to make sure that you order it from the pharmacy as soon as you can, or make sure that the doctors prescribed it on the drug chart system so that you can give it on time as well. And insulin is one of the examples as well of critical medications. What else? Steroids, strong opioids, antibiotics, anticoagulation, and all the medicines used in emergency situations such as resuscitation drugs. And then number 6 is not checking for allergies or medications expiry date. I put it into practice when I'm giving medication. I still make sure that before giving the meds, I check the allergies because there was one time when the doctor prescribed Tazozin. It has penicillin in it and the patient has allergies to penicillin. A good thing that I didn't give the medication. I told the doctor that the patient is allergic to penicillin and they had to change it. Before me, the patient already had 1 dose of this antibiotic and he didn't have any anaphylaxis, but he was having like bloody stools. So I think that was the effect for him. That's why they put it on the allergies. So sometimes it could be allergies or intolerance to the medications. And then sometimes we also don't check the expiry date of medications. We just give it. Although we could be really busy, we could be distracted as well. And sometimes we forget checking the expiry date. It just takes 2 seconds to check the expiry date anyway. Number 7, not checking the blood sugar when needed. When you just receive a patient who is diabetic, you have to know what was the blood sugar as soon as you receive the patient. Especially when they're taking insulin as well. They could really have hypoglycemia and that is life-threatening. So just be careful. Make sure you do the proper assessments and prioritize what is important. Number 8 is not checking patient's body weight when giving paracetamol because some people could be less than 50 kg. The usual prescription here for adult is 1000 milligrams, but if the person is less than 50, such as like me, I'm only 46, 47 kg, so I need only 500 milligrams of paracetamol or else I could potentially have an overdose of the paracetamol. So yeah, if you see that the patient is small, then double check the weight, or if the weight that was recorded was the latest one or is that like an old one. Number 9 is not discharging patients properly. So for example, you forgot to remove the cannula, or if they have stitches, you still have to give them extra dressings and make sure that they have everything before they go home, like discharge letter, their medications to go home with. You have to make sure that everything is removed before they go home and that is safe for them to go home as well. I think I had one where I forgot to give a patient some dressings to go home with, or like gauze or things like that for the wound. So yeah, I got told off by our band 6. because the patient called asking like what I'm gonna do with my wound and all that, and then I discharged the patient. It was too busy. I was just new in the ward as well, and I forgot. So sorry. Number 10 is not checking patient's skin during admission and in every shift. Most especially if you have a patient that is bedbound. Because if you don't check and they already have like a pressure sore and somebody else took the patient and the pressure sore is like category 3 already and you were the nurse who accepted the patient, then you're gonna be questioned. You're gonna be told off. You're gonna be blamed about that because you didn't check patient skin. You know, here, patient skin is one of the important things that we need to protect as a healthcare professionals. So, yeah, if there's a tear or broken skin when the patient comes in and you admitted this patient, you have to document that. And we have tissue viability nurses where they are the ones we talk to if we have patients who have pressure sore. They usually assist us and give us advice on what dressing to do depending on the category, and they sometimes look at the patients. They review the patients in the ward and they give us a guidance on what to do with the wound, what is the dressing, what do we need to put, and things like that. What else? That's my list, but there's still a lot more. Maybe I'll just add like a lot of the day text or incident report that I have been observing before. It's like falls, patient fall. So you have to make sure that the patient is safe. If they're pressing the call bell, somebody needs to answer the call bell as soon as possible, especially at nighttime because they might be desperate to go to the toilet. And that's one of the reasons that people fall is because they couldn't see at night. Like it's too dark at nighttime in the ward and they're just too frail to be moving around. They need assistance from someone. You have to do things to prevent falls. So there are like the anti-slippery socks and making sure that the call bell is within their reach, because if they don't have the call bell, how can they call the nurses, especially at nighttime? That's also one of the reasons where patient falls, because they don't have the call bell and they're too desperate to go to the toilet. They just had their surgery and with their desperation, they just ended up hurting themselves and falling to the floor. And that's it for today's episode. I hope you learned something and I hope you subscribe to my channel. I'm also in Spotify, so if you don't have any time to be watching my face, that's okay, my cringy face. You can just listen to my cringy voice in Spotify. I'm gonna include the link down below. So see you later. Bye.